Francois Depass, and he is presenting a satellite talk for STAGO. Dr. Depass joined Diagnostic STAGO as a director for clinical development. His position includes networking with key opinion leaders, learning societies, and clinical laboratory associations, as well as development of partnerships with the pharma industry. He developed educational tools in the field of hemostasis, and he authored and co-authored more than 150 papers, posters, and oral presentations, both nationally in France and internationally. And he issued pre-analytical recommendations for coagulation parameters at the request of the French Ministry of Health. He is a member of the International Society on Thrombosis and Hemostasis, the American Society of Hematology, and the Clinical Laboratory Standards Institute, working also with the German Institute for Normalization, and a member of the development of a reference measurement system for sustainable PT-INR standardization. He seems to have really impressive input and contribution in the field of diagnostic coagulation. And he's going to talk to us, or we're going to hear about the laboratory assessment of antifactor 10A for the heparin and the direct anticoagulants. So we can proceed.
So hello everyone, it's my pleasure to be with you today to discuss this important topic from both a laboratory and clinician perspective of monitoring anti-10A drugs. Actually, the modern era of anticoagulation started in the last century, in 1916, when MacLean discovered unfractionated heparin, and the first clinical use of unfractionated heparin was in the 1930s. 50 years later, low molecular weight heparin were launched on the market, and you have here a couple of names, of commercial names, of those preparations. In 1996, the danaparoid sodium organ was launched, and then, a couple of years later, in 2002, fondaparinux, the synthetic pentasaccharide, AntiXa, was launched. In 2008, rivaroxaban was approved by the health agencies, and then apixaban and finally edoxaban in 2015 were launched, and those three drugs are direct factor 10A inhibitors. Unfractionated heparin, low molecular weight heparin, and danaparoid sodium are prepared by extraction of animal tissues, while fondaparinux and direct factor 10A inhibitors are very well defined chemical compounds which are synthetic. Unfractionated heparin, low molecular weight heparin, danaparoid sodium, and fondaparinux exhibit their anticoagulant activity via antithrombin to potentiate the capacity of antithrombin to inhibit factor 10A, while direct factor 10A inhibitors inhibit directly factor 10A without the intervention of antithrombin. Unfractionated heparin, low molecular weight heparins, danaparoid sodium, and fondaparinux are drugs which are used by the parenteral route, which means a subcutaneous or intravenous injections for unfractionated heparin, and subcutaneous injections for low molecular weight heparins, danaparoid sodium, and fondaparinux. In contrast, direct factor 10A inhibitors, rivaroxaban, apixaban, and edoxaban, are used by the oral route. So, unfractionated heparin is a mixture of polysaccharide chains of a molecular weight ranging from 5,000 to 40,000 daltons, with an average of 15,000 daltons. And approximately 1/3, 20 to 40% of this polysaccharide chain contain a unique sequence of 5 monosaccharides, which are here depicted in gray, and those five monosaccharides constitute the pentasaccharide, which is the minimal sequence that binding to antithrombin will potentiate the inhibition of factor Xa by antithrombin. Those unfractionated heparin chains can equally inhibit factor Xa and thrombin, the factor 2A, meaning that those unfractionated heparin has an anti-10A to anti-2A ratio of 1. And this means also that unfractionated heparin will significantly prolong the aPTT, which is a rationale for using aPTT to monitor unfractionated heparin. Low molecular weight heparins are prepared from unfractionated heparin by depolymerization, either chemical or enzymatic, to lead to smaller chains with a molecular weight of 2,000 to 10,000 Daltons, with an average of 4,000 to 5,000 Daltons. 1/3 of these chains also contain the pentasaccharides, this sequence which is required to bind to antithrombin and potentiate the anti-10A activity of antithrombin, but only a minimal proportion of those chains are long enough to combine both with antithrombin and with thrombin to inhibit thrombin. This means that the length of the chain requires at least 18 monosaccharides to be able to inhibit thrombin, which means that not all the chains of the low molecular weight heparin will have the ability to inhibit factor 2A or thrombin, while all the chains may inhibit factor Xa, provided they contain this pentasaccharide sequence. This means that low molecular weight heparin exhibit a more pronounced anti-10A activity than the anti-2A activity, and that the anti-10A to anti-2A ratio is above 1. So, how do low molecular weight heparin prolong aPTT? This depends actually from the anti-10A to anti-2A ratio, and you have here on the y-axis various preparations of low molecular weight heparin versus on the x-axis the anti-10A to anti-2A ratio. And the lower the anti-10A to anti-2A ratio is, the higher is the prolongation of the aPTT, which means that tinzaparin, which exhibits an anti-10A to anti-2A ratio of 1.8, will prolong more the aPTT than bemiparin, a low molecular weight heparin with a more important anti-10A to anti-2A ratio, and the other low molecular weight heparin preparations will have an intermediate profile. This means that aPTT is not an option to monitor low molecular weight heparin, and only anti-10A activity is relevant to monitor or to measure the anticoagulant activity of low molecular weight heparin preparations. And this is depicted here, where you have a table summarizing some of the available low molecular weight heparin preparations, starting here with bemiparin on one hand, with a molecular weight of 3,600 Daltons and an anti-10A to anti-2A ratio of 8, versus the opposite, the tinzaparin, with a higher molecular weight of 6,500 Daltons and an anti-10A to anti-2A ratio of 1.8. Nadroparin, enoxaparin, and dalteparin exhibit an intermediate profile. And what is important is that the therapeutic range provided for those low molecular weight heparins that you can see here, measured at peak, which is the Cmax, is different from one low molecular weight heparin preparation to another, which means that you need to refer to the actual low molecular weight heparin preparation used in your patient to check whether your patient is within the therapeutic, specific therapeutic range of this low molecular weight heparin preparation or not. And you cannot consider a kind of a generic anti-10A activity reference range of, for example, 0.5 to 1 international units per mil for all those low molecular weight heparin preparations. You have to refer to specific therapeutic ranges. So, we have already said that UFH prolongs significantly aPTT, and this is a rationale for using aPTT to measure or to assess the anticoagulant activity of unfractionated heparin. We have seen also that depending on the nature of the low molecular weight heparin preparation, some of them may or may not significantly prolong the aPTT. And for that reason, we have already said that aPTT is not an option to measure the activity of low molecular weight heparins. Of course, because unfractionated heparin exhibit an important anti-2A, anti-thrombin activity, the thrombin time is prolonged by unfractionated heparin and less prolonged by low molecular weight heparin, again, depending on the importance of the anti-2A activity versus the anti-10A activity. Prothrombin time is not prolonged by UFH and low molecular weight heparin. This is not because it is insensitive per se, it's because it contains a heparin neutralizer that makes it insensitive to heparin, either unfractionated heparin or low molecular weight heparin. Danapa with sodium does not significantly prolong PT or aPTT or thrombin time, and this is because, of course, this is a pure anti-10A compound with no antithrombin activity, and the same applies for fondaparinux, rivaroxaban, apixaban, and edoxaban, which are also pure anti-10A compounds, which means that they do not prolong the thrombin time. The prolongation of PT and aPTT varies across these preparations, these drugs, but this is usually a minimal prolongation, and for that reason, they cannot be used to monitor those drugs. So if we summarize what we can do with aPTT versus anti-10A here, we can see that we may use the aPTT to monitor unfractionated heparin, but this is the only anti-10A drug that you could monitor with the aPTT. For all the others, aPTT is not suitable. In contrast, the anti-10A activity assay is valid for all the anti-10A drugs. So, coming back to the monitoring of UFH with aPTT, and first we should start with an historical background, because all these reference range that we use today, saying that the aPTT prolongation should be somewhere between 1.5 and 2.5, or between 2 and 3, the ratio between the patient and the control, relies on a historical study conducted 50 years ago, in 1972, on a small set of patients, 234 patients, which were included because they had a lower limb DVT diagnosis solely based on clinical criteria with no imaging testing, which is a great limitation. And we don't know either which was the value used for the control, for the calculation of this patient to control ratio. We don't know if it's the median, the mean, the upper limit of the reference range, a value obtained on normal pool plasma on the same day. We don't know what was used. And with that, the authors concluded that the therapeutic range corresponding to this ratio was an activity of 0.2 to 0.4 international units per mil, measured by protein infiltration, which corresponds to 0.3 to 0.7 international units per mil of anti-10A activity with the assays that we use now.
is also important to see that the reagents that were available in 1972 have nothing to do with the reagents that are now available. And in this study conducted in 2012 by Isabelle Coin-Thibault in France, she compared the sensitivity of various aPTT reagents here on the x-axis versus the aPTT prolongation here on the y-axis, corresponding to the therapeutic range expressed in international units of anti-10A activity. And you can see that there is a great variation across these aPTT reagents, and this means that when you make the choice to use aPTT to monitor unfractionated heparin, you have first to check which is the ratio corresponding to the actual therapeutic range expressed in anti-10A activity before you monitor your patients. Furthermore, a few years later, Richard Ballard from the USA showed that there is also an interlot variation of the sensitivity of aPTT to unfractionated heparin. This means that once you have determined your therapeutic range with your specific reagent, each time you change the lot, you have to do a lot conversion, and this makes this lot conversion quite cumbersome. Finally, it has also been shown that the responsiveness of your aPTT also depends from the analyzer that you use. And you can see here that depending on the mechanism of detection of the clot, here optical versus mechanical, you may also have significant differences. And this is illustrated here, where you can see that you have here a reagent A on the left-hand side and a reagent B on the right-hand side. And you have 4 different instruments, which are depicted with different triangles or cycles, plain or empty. And you can see that there is a clear difference depending on the reagent, but also on the instrument that is used. And this is also depicted here, where you have various instrument combinations, 4 instrument combinations on the x-axis, and you have here the result of the aPTT on various quality controls, external quality controls during several years. So, of importance is that the reagents that you use, the lots that you use, and the instruments that you use may have a significant impact on the aPTT that you measure when you monitor unfractionated heparin. So there are pros and cons for using aPTT for UFH. Pros is that this is the historical assay, and for that it has been used for years, and people are very used to these values. The reagents, the aPTT reagent, is widely available, and it's a cheap reagent, which means that the cost is very limited. But as cons, we have also this historical background, because I showed you the limitations of this study dating from 1972. And I have also shown that determining the UFH aPTT therapeutic range is a cumbersome process, which has to take into account the initial reagent and instrument combination, but also the lot conversion that you have to do every time you change the lot. Also, the aPTT is sensitive to multiple interferences, such as factor levels, especially factor VIII and fibrinogen, which are acute phase reactants. Lupus anticoagulant is also impacting the aPTT result, and the level of CRP, C-reactive protein, another acute phase reactant may also impact the result of the aPTT. And furthermore, there is no specific calibrator for aPTT for measuring UFH, and there is no specific controls for aPTT when you measure unfractionated heparin. And may I remind you that it is a requirement from the accreditation or certification process to perform specific quality controls. So the anti-10A chromogenic assay is actually a universal tool for all anti-10A drugs. So you have here the principle of the assay, and what is important is that when you use an anti-10A chromogenic assay, the calibration, the calibrator is traceable to the UFH international standard or to the low molecular weight international standard or to the danaparide international standard. And the direct anti-10A drugs, for the direct anti-10A drugs, also the calibrator is traceable to the reference compound rivaroxaban, apixaban, or edoxaban. And you can see that for the unfractionated heparin and low molecular weight heparin, you can also use an hybrid curve that will allow you to have results for both unfractionated heparin or low molecular weight heparin with the same calibration curve. And of course, you have dedicated quality controls for all those compounds that are available. So there are some benefits in addition to the analytical benefits. There are some benefits, for example, in ICU patients. So in this study, the authors say that the aPTT is less accurate than the anti-10A activity assay in detecting UFH or underdosing and overdosing, and they suggest to use anti-10A rather than the aPTT. Furthermore, when you use unfractionated heparin, you have to reach the therapeutic range, and it has been shown that the time to reach this therapeutic range is shorter when you use the anti-10A activity to monitor UFH than when you use the aPTT. And there are also less dose adjustments the first 24 hours of treatment when you use the anti-10A activity versus the aPTT. And finally, and last but not least, I would say there are significantly less bleeding events when you use the anti-10A activity assay than when you use the aPTT. Patient blood management is also a matter of concern. And in this study conducted in a huge number of patients, 20,000 inpatients, the authors have demonstrated this strong association between the use of the anti-10A versus the aPTT and the reduction of packed red cells transfusion. So again, an important benefit for the patients. There are some recommendations regarding the Preanalytics for measuring unfractionated or low molecular weight heparin, just because heparin can be neutralized by platelet factor 4, which is released by platelets in the blood sample. So if you use a regular citrate tube, you have to make the measurement either with the aPTT or the anti-10A activity not more than 1 hour post-blood draw. But if you use CT-AT tube, which contain a platelet stabilizer, then you may measure the aPTT or the anti-10A activity up to 4 hours after the blood draw. For direct anti-10A drugs, you can use a regular citrate tube because there is no neutralization by platelet factor 4. Also, the time of blood sampling is important. So this is the recommendation for unfractionated heparin. So you can use unfractionated heparin either as a continuous intravenous infusion, and then you can draw the blood anytime after the first hour of infusion, But if you use an intermittent subcutaneous injection, you have to draw blood at midway between two injections. For low molecular weight heparins, which are administered subcutaneously, it depends if this is a twice daily injection for the curative dose, and then you have to draw blood 3 to 4 hours post-injection to reach the peak, or if it's a once daily injection for a curative dose again, then you have to draw the blood between 4 to 6 hours post-injection, again to be at the peak and to be able to compare to the reference therapeutic range. For fondaparinux, those Cmax is indicative, but around 0.39 micrograms per ml, with a Tmax at 2.8 hours and a a trough level of 0.19 micrograms per milliliter. For the DOACs, this is summarized here, and you can see that for some of them, there is a huge overlap between trough levels here and peak concentrations. And furthermore, the actual indication for measuring the anti-TNA activity of direct oral anticoagulants is emergency situations. And in those situations, you don't know if you are at trough or at peak. And most often, you are not at trough, neither at trough nor at peak. So it has been invented this concept of on-therapy range, which is defined by the 5th percentile of the trough and the 95th percentile of the peak. So the take-home messages from my lecture is that aPTT is a historical test to monitor unfractionated heparin, because the test is also cheap and routinely available, widely available. But as I mentioned, it's based on a historical study in a small patient population with multiple limitations, which is the inter-assay and even interlot, inter-instrument, UFH sensitivity variability, the absence of an international standard, and the absence of dedicated QCs. And this makes the aPTT lack of standardization. In contrast, the anti-TNA assay is a universal, versatile, standardized automated assay for all anti-TNA drugs. It's a chromogenic assay which is as easy to run as a blood sugar test. It is fully automated. This is the same ready-to-use reagent in a liquid form for all anti-TNA drugs. And there is a long reagent on-board stability of 7 days. So there are dedicated calibrations traceable to reference materials. There are also dedicated QCs, and there is no interference with factor levels, plus anticoagulant and CRP in contrast to the aPTT. And we have shown that there is an improvement in the patient management in terms of outcome and in terms of cost effectiveness. And if you want to learn more, may I recommend you our practical manual series with 2 issues, one on the parenteral anticoagulants and the other one of oral anticoagulants. We have also 3 webinars related to the topic of today and 2 podcasts. I thank you for your attention, and I will be very happy to take questions if there is any. Thank you.